All right. Welcome, everyone. I see we've got a quorum here, so we'll get started. Welcome to this webinar series that we're kicking off today here with Scott Ellsworth and myself. Appreciate you all jumping on and looking forward to digging in here. The theme for today, as we outlined in the materials that were shared online, is really going to be to try to slice the onion around how to negotiate with payers on behalf of the provider from a position of strength and with leverage. We're excited to kick this off today, not just with myself, but with an esteemed guest of ours. The outline for what we're going to be doing today will be as follows. So we're going to start off with Scott Ellsworth kicking off his presentation on some key things to consider as we go into negotiations and how to actually build leverage through that process. After Scott spends maybe 20 or so minutes on that, I will go ahead and jump in and showcase some of the capabilities that here at Trek Health we've built out to support providers and health systems in using real data to drive those negotiations. And the final 20 minutes or so, we want to keep open to Q&A. So again, for anybody that's just joining here, I want to really encourage everyone to use this Q&A functionality that we have built into the Zoom chat here to ask questions as we go. With that being said, I'm going to maybe just do a quick introduction on Scott Ellsworth. So Scott is the president of Ellsworth Consulting, consulting firm today that's supporting many health systems across the country in negotiating across payers. Today, Scott has helped negotiate upwards of $10 billion in provider contracts, resulting in upwards of $2 billion in incremental revenue for the clients that he works with. He comes from a background on the payer side from serving as president and CEO of Centene West, where he led operations across 10 states with a $15 billion P&L. And prior to that, worked at organizations like Optum, Excelis PCBS, and otherwise. Scott is a industry leader. And as we at Trek Health have been building out our platform, have really looked to folks like Scott to help drive our strategy to make sure that we're building things the right way. And really appreciate you jumping on here, Scott. I will hand it over to you.
Yeah, thanks, Dilpreet. Appreciate it, and appreciate you and the folks at Trek for having me today, and thanks for everybody joining. So, yeah, I mean, I think you summed it up. My career's all been in healthcare. I'm a 30-year payer guy, and a couple of years ago left Centene. Actually, was asked to help with a client, a large hospital system, help with their negotiations, and we had a really positive outcome. And next thing I know, my phone was ringing, and haven't looked back, and enjoyed today working with a dozen or so clients currently across the country on all things managed care, payer contracting. So, what I wanted to do today, what Dilpreet and I talked about, was I'll just walk you through kind of high level how I think about payer contracting, how I think about supporting providers, kind of some approaches and in hints or tips, and hopefully some of it's helpful. But I think, as you'll see, data plays a central role in at least the way I think about negotiating with payers, and I'll talk a little bit more about that. So, yeah, if we want to dive right into it, Dilpreet. So, earlier this year, I was at speaking in Tampa at an HMFA event. And, what was really interesting, there was a CFO panel that came up after my session. And, it was just really, maybe not eye-opening, but really reinforced a lot of what I'm hearing from providers, health systems, just the struggles with payers, this down coding, denials, slow pay, low pay, no pay policies, and really the struggle they're having with reimbursements not keeping up with inflation. And so, it's a significant challenge out there. In a group like that, if you ask folks who thinks they're being, paid fairly today by reimbursed appropriately, not a lot of hands at the room would go up. And so yeah, it's obviously top of mind for almost every provider right now are reimbursements, especially with what's happening in Medicare, Medicare Advantage, the growth, the low yields in Medicare. But if you want to jump to the next slide, Dilpreet. So, one of the things that I think you would hear me continue to say, and I know, my former payer colleagues would probably not feel real good about hearing me say this, but the reality is payers don't negotiate in good faith. I'm not saying they're bad people, but payers use leverage. And today, with the consolidation among a dozen very, very large payers, they largely use leverage in their negotiations. And the point here is um, providers should as well. And yeah, not everybody has the same leverage as HCA or the largest health systems, but every provider is critical to their community, and so understanding that is really important. I won't walk through all of this, but it's a little bit of a framework that I often run into too many folks that on the provider side that are still feeling like if we just operate in good faith, if we just do the right thing, if we just sort of make a good case and show them how good we are and how important we are, and even if we show them a little bit of data, ultimately we'll get to a good number. And the reality is the clock usually runs out and they don't. And so, you'll hear me talk about really understanding, the end-to-end process, understanding payer approaches, which are largely to just run the clock out. And then, it's December 31st, and what am I going to do? And now it's too late. I just have to take the last best offer. So really, thinking strategically about your negotiations, and in the next slide, I'll kind of lay out what I think are kind of at least the framework that I use with most of my clients. And we'll circle back on kind of the bottom right, what I've dubbed here this power move, but really understanding ultimately your greatest leverage with payers is your ability as a provider to move patients. Patients are more loyal to you than the logo on their ID card. Understanding that largely, especially seniors, aren't going to change doctors, and understanding how to use that is the greatest leverage that providers have. But you want to jump to the next slide. Thanks, Dilpreet. So, this is the framework I kind of use the template with all of my clients. Not every step here applies to everybody, and it, doesn't mean that every situation's ideal. Sometimes you just, go into a situation and you just got to deal with what you have. But starting early is important. Recognizing, especially, that it takes time to really understand the data and in where you are in the market. It takes time to understand, what offer position that you're going to take. Give yourself time. Starting late just puts you in a very weak position. If someone called me today and said, "Hey, I've got a big renewal coming up with United for January 1," boy, you've really put yourself in a difficult spot. There's just, even though it seems like we've got, a lot of time left, the reality is you've missed some key opportunities and some key windows at the negotiating table, and you've really deleveraged yourself pretty badly. Getting alignment, again, depending on the group and the provider, the larger the group, the harder it is to get everyone aligned. And that takes time. And the point around alignment is get that up front, especially if you're a hospital system. You've got a lot of key stakeholders, making sure they understand the data, your situation, what's coming up, what you may or may not run into. Really important to engage, even board level engagement early in the process. You don't want the board, hearing about a difficult negotiation for the first time with an article in the newspaper. You need to get folks aligned really early. Payers count on providers, especially hospital systems, not being aligned, and ultimately, count on them caving at the 11th hour because, people really weren't prepared for, a tough negotiation. We'll talk more today about data and just the importance of data. Today, there is data out there. You really do need a partner like Trek to be able to get it correctly and understand it, because it's a credibility issue. You've got one chance to kind of put data forward, and if you don't have it right, it can just blow up your entire negotiation. But understanding where you are in the market relative to others is incredibly important. In today's world with the data that's available, the price transparency data, again, with few exceptions, you're making a mistake going into negotiations without at least knowing where you stand relative to others for a particular payer that you're negotiating with. So, can't say enough about the data, and it's a credibility issue. It also helps internally align. I say to my clients, I'm not a fan of just shooting for the moon and seeing what sticks. Payers are used to that. It's a bad strategy. If you really know where you're at, you know where you need to be. Not only does it build a credible story, but frankly, it gives you internal sticking power. If other folks are getting 15% more, gives you a lot of fortitude at the negotiating table, and you ultimately know that the organization's going to have your back. Rates and language, everybody, of course, rates. Everybody wants to talk rates, and that's always the elephant in the room. But language is just incredibly important. Really understanding, your contract, what language you have in there, what are payers trying to get into the contract that, again, gives them more leverage around things like down coding, denials, etc. Often that can claw back hard fought wins on the rate side through unfavorable language. Doesn't mean everybody can negotiate a one-off deal with United. In fact, that's rarely going to happen. But just understanding what's in there, perhaps ability to push back on 1 or 2 points, get something favorable, is really important. Escalating. I often ask folks, are you negotiating at the right level? And again, it's difficult. Not everybody's going to get an audience with the CEO of a large payer to make their case. But the point is, if your only negotiating point is that frontline negotiator, they're hired, they're professionals. They're hired to say no. They've got budgets. They have limited authority, and in I'd say situations where it's really let's say a critical negotiation, you're significantly underpaid, the ability to escalate, the ability to have a dialogue with someone at a higher level, someone who is more of a P&L owner is extremely important. And just think through sort of who are you talking to? Are you really talking to a key decision maker? And if you're not sure, find out who their boss is and try and pull them into the negotiations. Figure out who the local market president is. Reach out to them. That type of thing. And then the last is leverage. Really understanding, what leverage you have. I like to say that providers have more leverage than they realize. I think everyone knows right now there's largely an imbalance of supply and demand out there. There's not enough doctors, especially primary care and certain specialties. The waits are crazy, and the point here is that builds leverage for providers. And there are a number of ways. I did an op-ed recently in Becker's around how providers deleverage themselves at the negotiating table and how they can build leverage. But really understanding that, how do you create leverage if you get to that point in negotiation where you've got to use that? What are the methods to build it, and what are you doing perhaps unintentionally that's deleveraging yourself at the negotiating table? And so I think I've got maybe one more slide. And so, I've tried to boil it down, what are some of the keys to success and successful negotiations? And certainly starting early, having a strategy, getting alignment is important. That's sort of table stakes. But the other three are really the most important. Again, data, really understanding where you are in the market, having good analytics. If you don't have a good health economics team internally, get some outside help. The data, it's just really important to have good data, good information, so you can frame the context of your negotiation, the context of your ask. It doesn't mean that payers are going to open up their checkbook when you show them that you're paying the folks down the street. They're paying them 10% more. But having that information today, especially, payers know that they're not going to be able to just randomly pay folks all over the board. That in fact, they're going to have to be accountable, or at least be called out when there's a significant difference in perhaps what you're getting paid over other folks. Another way to look at this is just, I think every client I go into, the first question we try and answer is, how much money are we leaving on the table? Right? How do our reimbursements compare? And that's sometimes the answer might be, we're getting top of the market. Okay, well then we just need a fair escalator to deal with inflation and whatnot. But understanding, are you leaving money on the table, and if so, how much? That's where Trek comes in. That's where the data comes in, the analytics come in. And again, I can't stress enough, you have to get it right, because if you don't have it right, the payers are going to call you out. Remember, this is their data, so you're basically showing them their data, and if you don't have it right, they're going to embarrass you. I talked about escalation. I think just understanding who you talk to. Are you negotiating with the right people? Can you engage higher level executives at a payer who understand more broadly the context of the dynamic of financing and delivery of healthcare? And that's something typically the negotiating team often is a little bit blind to. They're in a mindset of, I've got a budget, I've got to stick to a budget, I can only pay you this much, and that's it. If you can get to a higher level executive, they're often, they can see the bigger picture. I would tell you, from 30 years of running health plans, one of the things I always had to really stress with my contracting teams was, don't forget, the network is what we sell. And I would say to the folks on this call who are providers, you are the payer's product. You're the payer's product. It's not the benefits, it's not the premium, it's the network. And without the network, they have nothing to sell. Limited panel plans don't sell. And there's exceptions, and I know, in Kaiser and what have you, but by and large, broad networks sell. You look at the successful payers out there, they have broad networks. It looks like the phone book, Blue Cross, United. And so, big gaping holes, even if it's not an adequacy issue, it's a marketability issue. And back to the, the point of imbalance of supply and demand, not enough doctors, the fact that seniors don't change doctors. When we went through it with Anthem at Bon Secours, I had a broker say to me, Scott, there's two things seniors don't change. They don't change their pastor, and they don't change their doctor. And the point there is your patient and that patient loyalty to you as a provider is it a real asset, and it's real leverage at the negotiating table. And so, my point of that is payer executives aren't bad people. The higher level folks get that. It's just, are you able to engage those people and have that conversation? Because they know that if you are out of their network, it's going to cost them. And it's a business that organic growth is really hard. The folks that are left are so big. There's not a lot of acquisition, merger opportunities left. Can't afford to lose people. It's so hard to grow and add people. The last thing you want to do is lose people. And that really leads to the last piece here. I talked about kind of this 90-day move. It's a little bit more nuanced maybe than we can get into in this call. But, the point here is negotiate your hardest during open enrollment. If you're a provider, number one, try and align all your contracts to a January 1 date. Number two, negotiate hard, set internal deadlines that if you don't have a deal by 10/1, you're going to go public. Your ability to move patients, especially seniors, individuals, and even influence large group through open enrollment creates enormous pressure on the payers. They know ultimately you'll probably get a deal done on December 31st. The problem is the damage is being done now with you as a provider in the market, mailing patients in the media. It's heat that they don't want to take. And so just understanding that, right? If you've got a renewal that's coming up April 1, you're already in a very weak position, frankly, anything other than January 1. So just all of those pieces are really critical. I think that might be my last slide, Dilpreet. Oh, one more slide here. A shameless plug on the bottom about hiring a team, but have a strategy. Look, not every payer. Hopefully you've got a number of contracts you're happy with. You can't be at war with everyone at the same time. If you really go into a large strategic renewal that has the potential to include a public termination notice, I'm not saying going out of network, but going public, that is a heavy lift for any provider of any size. There's institutional fatigue there. You can't be battling everybody all the time. I like to say providers are on the side of the angels. Providers, you're here to deliver babies and save lives. Payers are financial intermediaries. They're never, ever going to win a public battle. But the point here is you can't be at war with everyone all the time, or at some point people do begin to wonder who is the bad actor here. So be strategic in terms of how you approach this. Recognize you've got a lot of leverage. Recognize you have to use that leverage. Payers, relationship. You want to have a good relationship with a payer, but it's got to be on an equal footing. It can't be a subservient relationship where they love you because you do everything, you bend the knee every time they ask you something. It's got to be on a level playing field. And so recognizing that, overweighting, hey, we want to be friends or we have a good relationship. I can tell you from my past life that the most difficult providers, the noisiest, the hospitals that I called the biggest pain in my rear, those were the ones that we paid the most. It's just sort of kind of the way the system works. Unfortunately, payers often don't reward high quality. They don't reward folks that do all the right things or embrace value. I'm not saying those are bad things. Those are all the right things to do. But when it comes to negotiating at least appropriate base rates, yeah, you've got to have a strategy. And, when you determine that you're grossly underpaid, you have to be prepared to go after it hard. So obviously there's a lot more in there that, maybe it's a follow-up webinar at some point, Dilpreet, on, Medicare Advantage,
Absolutely.
value-based, but I appreciate the chance to share a couple of thoughts here today.
Yeah, no, thank you, Scott. Great nuggets there. And I see we've got some engagement in the Q&A chat. We'll get to those questions here in just a few minutes. But appreciate the walkthrough. I think at a high level, the points are loud and clear. And I love that visualization of sort of the four pieces on the playing field here. And we really need to get all four in order to be able to design a negotiation strategy, timing, making sure that we're at market parity using data, escalating to the right people, and giving yourself the ability to actually make that checkmate move if needed. So appreciate the walkthrough. We will answer some of the questions that are coming in the Q&A, and I would encourage anybody that has anything top of mind here based on the nuggets that were just shared by Scott to go ahead and post in the Q&A chat here. What I'm going to do now for the next 10 or so minutes is spend some time on what we're doing here at Trek Health to arm health systems and provider entities with data. So this ties into it's obviously not the only thing that we need for negotiations, but as Scott mentioned, there's a big element of timeliness as to why now data is available in a different capacity than it was even a few years ago. And so happy to spend a little bit of a deep dive here. Just by background, for those that might not be familiar with Trek, we've been around for 3 years. We're a Silicon Valley-based venture-backed organization that is pursuing accessing transparency data. So many of you on this call, I'm sure, are very aware of the transparency rulings that were put out by HHS and CMS. Obviously, there's the health system and hospital component that requires charge masters to get put out by the health systems. But one big component that was put forward in this ruling from 2020 that took a few years to go into effect was, as of July 1st of 2022, every commercial health plan has to now publish effectively their fee schedules. So at the provider level, so we can see NPI numbers, tax IDs, and billing codes. With that level of granularity, the payers are now forced to publish in-network allowed amounts as well as some out-of-network rates. The challenge, however, is that these payers are really doing what a lawyer would do during a deposition by over-publishing data. And an anecdote that I would use to highlight this is if you were to do a Google search today for United Healthcare's machine-readable files that they're publishing for the transparency data sets, it's about 50,000 files, each of which can be upwards of a terabyte in size. That's an insanely large volume of data. We're talking about $2 million in just server costs to host that data if we were to ingest every little file that UHG is putting out. And that's very intentional. They're publishing data in duplicative ways. They're doing things such as publishing fee schedules for physicians that would never actually even render a particular service. And there's been a lot of work that we've had to go through here to not only ingest the data in an effective and efficient way, but summarize that in a useful way as well. So we've spent the past 2 years or so going through these data sets that are getting published by payers, and today support upwards of 120 payers across the country on our platform. We re-ingest these data sets every 3 months on a quarterly batch process and make it available for entities to view and manipulate with a few key features, including a group rate research component that allows you to do a deep dive for a specific competitive entity that you want to do research on. We have a benchmark report and a rate change analysis tool that allows you to do a market scan, but also understand where there have been successful negotiations and what those successful negotiations look like in terms of actual changes in rates, and a lot of other things that we've pre-built into the tool. I'm going to now stop sharing screen and open up a couple components of our platform just to highlight what this actually looks like here in practice. All right, so as a partner of Trek Health, you would have access to a self-serve tool that has all of those components of the platform that I just mentioned: benchmark report, group rate research, et cetera. I'm going to spend a few minutes just highlighting a couple examples of highlighting what we can actually do with the data quickly if we were to get access here. So the first report that I've pre-built here is a view into institutional rates. So Trek Health has a pre-built report here for a handful of example DRG codes for general acute care hospitals. I happen to be in the state of California, and in this case, we're looking at United Healthcare. I'm going to zoom in a little bit here so that we can get maybe an easier view via Zoom. But what I'm seeing here is actually the statewide average. In this case, for all commercial in-network contracts for United Healthcare, the average in-network negotiated rates for these 4 DRG codes. And I have the ability to do a market-wide scan as well. So as an example, if I wanted to actually see what particular geographies have higher rates, are there any particular areas where payers seem to be providing higher rates based on cost of living or density of in-network providers, I can actually see by zip code grouping what these average rates look like. And we group these into zip code-based regions so that you can see what the dynamic rates look like here. And just to give you a sense of what we're doing behind the scenes, every component of our tool allows you to do the drill down to the level of the provider organization's name and their tax ID. So this is not just high-level market benchmarking that you're getting access to, but actually identifiable information as to who these entities are, where rates are being reported by the payer, and you can get down to even the level of the plan that the state is being reported from, and many other things. One other component of the tool that I want to highlight that you can do here within our platform is actually mapping professional rates as well. So institutional rates clearly would be published at the group or facility level, but there's a big challenge with professional rates, given often the rates are getting posted at the NPI type 1 level, or the individual physicians where the rates are getting reported. And so as an example, we also have a report here where we can see for professional services, in this case, for psychiatrists across the state of California, what the average rates are for common codes. And Trek Health has pre-built a lot of additional reports here. So for example, I can click this Medicare button and see what these commercial rates look like as a comparison of market Medicare rates. I can also see what the spread of rates look like here by entity as well. And if I wanted to drill down, I can do a lot of interesting things within the platform. So as an example, let's say I'm a large participant in a given market, and I don't want to compare myself to all of the providers in the market. We also have the ability of saying, well, only show me those providers that are maybe at 200% plus of Medicare, so that I can narrow in on only those entities that I consider to be like size or comparable to myself. And with this, I have the ability now to see amongst this subset the data that's only being presented for those that are above 200% of Medicare. And I can again drill down and see these entities in great detail. So without going much further into the platform, I can spend many hours here going through this in detail. We have pre-built many views that allow users to do a market scan. As you can see, few filters to get to that raw insight. And changing the payer that I want to actually examine is as simple as just editing the filter. So in this case, we were looking at United Healthcare. If I wanted to see maybe Blue Shield of California for the same constraints, I can just rerun a report, edit the payer name, and we're good to go. So this is all built on what we've learned by working with about 120 entities across the country, from health systems down to provider entities and MSOs and IPAs that we support, all to help renegotiate contracts with payers. And one innovative component of the tool that I'll highlight before wrapping up for now is since Trek Health has been in this market for the past 2 or 3 years, we've started to really consolidate a lot of longitudinal data. So one feature that, to my knowledge, we're the only that are in the marketplace today that are able to present this level of granularity is changes in rates. So let's say for BCBS Texas, for a DRG code, for general acute care hospitals, I actually want to see what rates have actually been successfully negotiated and what the percent change looks like. We have a component of our tool here that lets you do exactly that. So as I scroll through this, you'll see that we have old rates new rates and a percent assigned here. And I can actually back this up by clicking into any one of these examples and seeing maybe for this HCA hospital in Houston, I can see that for this particular entity, when I click in and look at the raw rate for the Blue Choice PPO plan, back in November of last year, there was a rate reported here at about $40,000. In April of 2024, there was an updated rate posted by the payer, $42,000. And so we can see there's about a 4.7% rate hike here. And I can actually see at the entity level or cross markets what successful negotiations have looked like. So without getting much further into the details, I will pause there. And I see we've got a handful of questions here that I want to maybe pass along here to you, Scott. So maybe just to get started with the first question. The question is, when engaging in rate increases with payers, how do you suggest getting access to payers' executive leadership? Do you suggest directly requesting the payer rep to connect you with the leadership, or what should the provider actually do? It seems like a tactical question, but I'll pass that to you, Scott.
Yeah, no, it's a great question. Look, it can be really tough to do. For obvious reasons, the contracting team is very protective of their leadership. Honestly, they don't want their leadership involved because when leadership gets involved, leadership tends to play Santa Claus and give money away, and it drives the contractors nuts. So they'll try really, really hard to keep you from talking to anybody at a higher level. In fact, if they know you're trying to do that, they'll often, kind of either try and discourage you and or make threats that, it's not going to do any good and that type of thing. Keep going. And so I think the answer, Rich, is any way you can get there, right? Any way you can get there. If you happen to know someone on the board, if it's a friend of a friend, direct outreach. I would not ask the contracting folks to connect you. Largely, I think that tips your hand, and they're likely not going to do it anyway. Anyway, if you can connect with somebody that's outside of the contracting silo, someone who's a market president, these are relationships. Frankly, if you have something coming up, if you can build it ahead of time, if you're a hospital, it's really easy. Often, invite the local market president in for a tour of your facility. Worst case scenario, right? You may have to engage somebody on the outside who has relationships. That's one of the kind of the benefits of what I'm doing. I've got a payer Rolodex. So, for example, I know, senior folks at Anthem, the head of contracting, and I used to work together at a Blue Cross plan. So, but yeah, it's tough. It's not easy. Worst case scenario, direct outreach, send a letter, send an email to the CEO, start at the top and just, request a meeting to maybe just talk about your group and how you can better partner with them, what have you, but not easy to do.
Excellent. Next question on the docket here is, do you encourage your clients to communicate directly with members of the community about the negotiation process? Does marketing, communications, PR, et cetera, create any leverage for providers?
Yeah, thanks for the question. Short answer is yes, but again, it's part of the timing. So you have to wait for the right time. And it's so early on in the process, no, but you do need to establish some deadlines. And if you don't have a deal by a certain date, right, typically 90 days prior, then you need to engage the community, need to engage your patients, need to engage your internal staff. You really have to have, frankly, a very professional, experienced corporate communications department. If you haven't been through it before, get outside help. I'm not a communications company. I've been through a bunch of them. I know the speaking points and the do's and don'ts, but I'm not an ad copywriter. I know some companies out there that do this and do it really well. But, the point is, if you get to that stage where, okay, we need to start telling our patients that unless we come to a deal, we're no longer going to be in network for ABC payer by January 1. You want to start that process. Frankly, that's a process that if you're in that situation, you should have launched that plan, probably mid-September, because the AEP actually starts today for Medicare Advantage. But yeah, there's you want to engage them. It's just engaging them at the right time, making sure that all your ducks are lined up. Make sure that you hit not only your patients, obviously internal. You have to think about regulators, legislators, key community leaders. Brokers play a big role. You have to have a strategy to engage brokers. Brokers control 90% of the business out there. Having a relationship with brokers, Medicare brokers, ACA brokers, group commercial brokers, there are 3 different groups. And yeah, there's a lot of work there, but the brokers will become your best friend if you let them and you work with them.
All right. And Michelle mentions here that she works for a large pediatric group. And the question is how you would suggest moving membership, specifically a Medicaid population where there's not the concept of the open enrollment process as there is for seniors.
Yeah, Medicaid's tough. My last gig was Centene, so big Medicaid plan, and Medicaid members are not as engaged. They're hard to reach. So I think, Michelle, sort of the answer is it does depend. It depends on your group and how you're positioned. If you're FQHC, that's a different aspect. Are you big enough where you could create adequacy issues, right? I think it's working, with the plan, ultimately with the state. But yeah, there's still leverage there. But the members moving, maybe not so much. But there's still, it's thinking about the timing, around the Medicaid reprocurement. So there's different leverage points around Medicaid plans, but patients are a tough one just because they're hard to reach, hard to engage, very different than, certainly different than Medicare.
And Richard Novi's asking about national contracts. So he's mentioning that as a multi-state provider, is there leverage in negotiating at the national contract level? And if so, what should a provider do if the payer is mentioning that national contracts are not something that they do and they do EIN or group tax ID based contracts at the state level?
Yeah, no, great question. So one of my clients is a national, one of the national ED groups, and is really took it on the chin with the No Surprises Act and frankly some bad actors and a couple of payers ripping up contracts. The national contract is tough. I think you have to really look at your footprint. You have to look at your current contracts. If you're in 20 states, but 3 states are the problem, I might argue you're better off not having a national deal. Let's just address those 3 states. There's an administrative issue there, and I think the payers, can be sensitive to that. So if you're truly a national provider group, or you're in more than 70% of the payers' markets, they're having to do exponential work as well with every state. So it depends on kind of what your goal is. If your goal is more administrative ease, you can probably align with them around that. If you're really looking to get a rate increase, thinking that, we'll leverage our national footprint. Again, hard to do just because the big nationals are so big. They're the leverage against them they're not going to feel a whole lot of pressure that way. But so yeah, I think it in and of itself, just a national deal alone may not be enough. I think you have to kind of unpack it a little bit and look at, strategically what you're trying to accomplish.
And Casey mentions that, as an example, a payer like United Healthcare is not open to negotiating before maybe 60 or 90 days ahead of contract termination. They gave an example of a contract terminating in January 2025 and payer pushing back and saying they're not going to negotiate until October. Is that something you would tie to sort of the stakeholder issue, getting in front of the right people, or what would you recommend doing if that's a pushback?
Yeah, no, this is a great question because remember the payer's playbook is stall, delay, run out the clock. So the payers know that number one, there's no advantage to them starting early. Number two, the later they start, the better, right? I think for most payers, if they start 45 days, again, if we're talking about a January 1 renewal date, open enrollment's almost over by the time you really get down to the tough negotiating points. And that's really what they're trying to do, is just retain their members, and then they know you're in a tough spot. So you have to start early. You have to set deadlines. You have to set milestones. You have to be resolute. You don't have to be a jerk about it or anything else, but you have to say, look, we expect an answer on this deadline. I just had a client. We sent our first proposal to a Blue plan 11 months before the renewal, and they sort of laughed at us, but they got a response to us 4 months later. But we kept right after it. We turned it around within a week with a counter, and we established our own internal deadlines, right? And ultimately, I think most of you're going to have to leverage notice of termination. Not in all cases, all situations. I'm not a scorched earth. I don't believe in going out of network's going to get you anything. In fact, when you look at most providers that go out of network, they end up settling. And if you know them, they'll tell you privately, we really didn't get anything more. So going out of network isn't the answer, but you do have to leverage notice of termination so you can tell your patients that you're going to be out of network. That's the key there. So establishing deadlines, if certain deadlines aren't met, these things are going to happen. You don't want to give them your whole playbook. You don't want to tip your hand, but you have to have your own deadlines, because they will never, ever, as Casey's saying here, they're always going to try and say, oh, we're too busy, we're this, we're that, we can't start. Well, yeah, of course, they don't want to start 90 days because most term notices are 90 days. Right? Once you hit day 89, they got you. What if, if you haven't given notice of term, what do you really have? You have nothing other than you're hoping in their generosity, and that's a bad place to be at the negotiating table.
Great call out. I see we have a question around the right contact that was covered earlier, so I'm going to jump along to Stacy's question here. Yes, Stacy, we do support ASCs here at Trek Health. The two examples that I gave when pulling up the platform were institutional rates for, in that case, general acute care hospitals. And I had some professional rates for physicians. For ASCs, we do indeed support CPT codes and HCPCS codes that would be relevant to ASCs. Trek Health is not removing any of the data that the payers are posting. The only thing that we would need to do is pre-built reports that are going to look at the right cohorts. So there are actually taxonomies, NPI-based taxonomies that are specific to ambulatory surgery centers that we can use to pre-build reports that would be relevant specific to ASCs. And the second question, Stacy, that you were posting around validating the rate changes by looking at actual negotiations. So when we're looking at the rate changes component of our platform, we're actually using only the payer data to look at data before and after. The only risk we really pose when we do that is if a payer is making just a standard inflation-based adjustment on the contract that might get picked up in our system as a rate change, and it's actually not a negotiation, but it's just a standard change that everybody got. We would be able to see that in the tool because we'd see that everybody or a large cohort of providers got a rate change in that case. So as a part of onboarding, what we would do for all of our customers is compare your fee schedules to the actual data that the payers are posting to identify any anomalies. But yes, we can support ASCs, and we have some ways of doing validation ahead of time as well. I see we have a question from Mile High Psychiatry. Yes, if you click on the Q&A section of the chat here at the bottom, you can see the questions that other attendees have posted. So let us know if you have any questions or issues with that. I see Adele from Christus has asked the question here: how do you combat large requested increases with health plans that have a majority of self-funded plans and use those large employers against you? Scott, I'll pass it over to you.
Yeah, Adele, if I'm tracking with you here, they're basically trying to blame providers for the rate increases that they're dishing out, or the cost increases that are going out to self-funded employers, and trying to get the employers to kind of be their shield to beat up on providers. That's sort of a standard play by insurers, right? They're protectors of affordability. I think you have to just have your own story. So, I talked a little bit about, right, inflation. So we all know hyperinflation the last couple of years, it's impacted everyone. You can't just go to a payer or a self-funded employer and say, hey, my costs went up, labor's up, I need more money. You have to have a good story about what you're doing to be efficient, be high quality, how you're different, what you're doing to combat costs, to lower costs. But there's a point where you can only do so much, right? Inflation's real, and at some point, so make it about workforce, make it about recruitment, retention of specialists, make it about investments in technology, plant, property, equipment. At the end of the day, make it about patients and patients first. That's kind of a mantra I have when things go public. Patients first. It's all about the patients and our ability to deliver on our mission, our vision for patients. And so, yeah, I think once you articulate that, you have your own little playbook, right? Your own little deck of kind of what we're all about and what we're doing to keep healthcare affordable. Look, there's no employer that wants to live in a world where they don't have, or their employees don't have access to high quality healthcare. And once they get educated of, what you do and how you do it, they're going to change their tune a little bit. You're not looking to, get them to flip and attack the insurance company. Don't bother. You're just hoping to sort of neutralize the speaking point of the insurance company, that it's the provider's fault that costs are going up the way they are. And, that's just simply not the case.
Absolutely. And I know we're running up here against time, so I'm going to try to pull a few of the remaining questions here. So Brian Cerna asks if Ellsworth Consulting negotiates with payers on behalf of provider entities. Definitely yes. We will pass along some materials and follow up here, Brian, so that in case any entities on the call today are interested in working with Scott or with Trek for the access to the data, we certainly would be happy to explore that, and we'll pass along some materials as a follow-up after this call. I guess there is one thing that's surfaced here by the folks at Mile High Psychiatry. I know many of the folks in behavioral health get pushback from managed Medicaid plans around negotiations, and they're told that MCOs don't negotiate. That's something that only commercial payers do. I guess, Scott, do you want to maybe comment on that?
Yeah. So there you can still negotiate with a Medicaid plan. I've seen ranges from 100 to 105% of Medicaid. So there is some room there for the plans. More importantly, you have to know your yields, right? So you have to know, this is back to having a good healthcare economics team or using somebody like Trek, but you have to know what your net paids are, right? Kind of what are you getting? You have a contractual rate, call it 100% of Medicaid, but when you get done with down coding, denials, the bing, the bang, the boom, even bad debt, what are you really collecting at the end of the day? So I just did this for one of my clients on Medicaid specifically. and the range was a low of 93.9 to a high of 99.8. And there were 5 different Medicaid plans. And the point here is those folks at the bottom, we're going to have a meeting with those folks. I don't want to, say who they are, embarrass them, but it's one of the bigger plans. And we have to have a meeting with them to say, look, your down coding, your denials are, significantly higher. And if we don't see a change, we're going to drop you. Because I think one of the strategies, and frankly, one of the most successful strategies in Medicare Advantage, figure out your yields, rank the payers, get rid of the bottom half. You're not going to lose patients if you do it and you time it right. The window's kind of closing for this year, but you'll move all those people up. You can probably improve your Medicare margins by 2 or 3%, right? 5% for half of your business going up to those others. And Medicaid's not a whole lot different. So take a look at the yields. Definitely tougher, right? Safety net product. You're not going to get a whole lot of sympathy from regulators, legislators. This is the safety net. So for the most part, you've got to make it up on commercial, as we have been doing for decades. But you can, every little bit helps, right?
Absolutely. I know we have some great questions here, but given we're running up here against time, I think this last set of questions that we have been asked here, we're happy to summarize some things on our side and share it as a follow-up, but likely won't be able to get to everything. I just want to comment on one thing that was brought up here, Richard, at the end. Trek Health is different from vendors in the marketplace like Fair Health because the data that we're pulling in is all tied to that transparency and coverage rule that I talked about earlier. Many vendors have existed in the marketplace historically that have aggregated claims data sets, either by procuring that from clearinghouses or working with health system partners, et cetera. Trek Health sources all of our data direct from these payer-reported machine-readable files and not from claims. And so with that being said, Scott, I really want to thank you first off for the time here today and sharing these nuggets of wisdom with the audience. Appreciate it. And also want to thank the audience for jumping on. I think at our peak here, we had close to 110 attendees. Thank you all for jumping on. We will go ahead and summarize some findings from this call and be sure to address some of the unmentioned questions here as a follow-up after this as well. And we'll go ahead and share a recording for any folks within your teams that maybe you'd like to share this with. And both Trek Health and Ellsworth Consulting will do some consolidated outreach afterwards. If you think consulting and access to the data platform is something that would be of interest to your organization, we'd love to have a follow-up conversation. And before we do that, we'll go ahead and share some materials for you all to take a look at. We want to make sure that we can support those entities that are ready for joining forces and actually going after these negotiations strategically. So thank you, Scott. Appreciate you jumping on here.
Thank you all.
Thank you, everyone. Hope you have a good rest of your day.